Chairman, dear colleagues, it's a great honor and pleasure for me to be part of this summit society. So the subject of my presentation is going to be comparison between vertebroplasty and kyphoplasty. Why to compare? So the study was performed in the clinic of neurosurgery, University Hospital St. Marina Varna, Medical University of Varna, Bulgaria. Why we compare both techniques? Because they are both percutaneous, minimally invasive. They're image guided. They treat painful vertebral fractures with injection of bone cement. They both aim to provide instant pain relief to prevent the further collapse of the vertebra. In the case of kyphoplasty, to restore the kyphotic angulation. Etiology is well known. It's the osteoporosis. They're elderly females and young steroid users. Why it's so important? Because according to the National Osteoporosis Foundation, about 100 million people worldwide are at risk for development of fractures secondary to osteoporosis. So the prevention is the most important treatment, but it doesn't depend on us. The complications associated with the osteoporotic fractures are spinal deformity, decreased lung capacity, physical activity, more bone loss, increased fracture risk, sleep problems, and increased mortality. The signs and symptoms are well known. The traditional management, we believe that the healing should occur within 6 to 12 weeks. Meanwhile, we are using analgesics, muscle relaxants. However, they have temporary effects and side effects. Immobilization with orthotic bracing with variable success, causing demineralization. The bed rest is associated with deep venous thrombosis, pneumonia. The classic surgery with transpedicular screw fixation with high failure rates. That's why the early intervention in both cases can reduce the duration of the acute pain, the occurrence of chronic pain, the height loss, the duration of immobilization, the use of analgesics, and the incidence of pneumonia. The purpose of the study was to compare the clinical outcomes, both techniques, the restoration of the vertebral body height and the spinal curves, the risk of cement leakage into the around the vertebra of both techniques. Vertebroplasty was first developed in 1984 by orthopedic surgeon French Deramont. He was treated a 50 years old female with a fracture C5 due to hemangioma. Then kyphoplasty was developed in the late 90s as a modification aiming to restore the height of the vertebral body and to reduce the cement leakage. They have similar indication or exactly the same indications. It's a pain related to VCF, 1 to 4 levels. It's old. Now we can treat more, 10, even 11, 12. Fracture presents less than 2 to 3 months. Recent worsening of fracture, no sign of sclerosis in the vertebral body. The contraindications are absolute contraindications when we have asymptomatic VCF, spinal systemic infection, uncorrectable coagulopathy, improving pain on medical therapy of fractures of the posterior elements when the body is intact. Relative contraindications are retropulsed osseous fragment in the spinal canal, burst fractures with a higher rate of cement leakage, or the loss of greater than 2/3 of the vertebral body height increases the technical difficulty of kyphoplasty. We start with patient examination, preoperative imaging. We must be sure for the intactness of the posterior wall of the vertebral body and the pedicles. We calculate the cup angles for kyphotic angulation. The pre-procedure care, antibiotics, they are optional. Anesthesia, we use general anesthesia. In our clinic, we use C-arm. The procedure is straightforward for both techniques. We use transpedicular approach. This synopsis of the vertebroplasty and the kyphoplasty itself. First, the introduction of the needles using the fluoroscopy, AP and lateral views. Venogram is optional. We use it in the beginning, just like a predictor of the pattern of cement injection. We can identify the direct venous communication. However, the contrast minimum interfere with the visualization of the opacified cement. Then in the kyphoplasty, we introduce the catheter with a balloon. We inflate the balloon, deflate. Then we are preparing the cement. In most of the cases, we have about 10 minutes, 10 to 15 minutes to inject the cement. The surgical technique, AP and lateral imaging on the C-arm. The postoperative care, the strict bed rest for 2 to 3 hours post-surgery. Then we instructed the patients to call if there is a new back pain, chest pain, or lower extremity weakness or fever. Follow up at 2 weeks, 1 month, and 3 months. In our study, we have 47 patients in the vertebroplasty group, 65 in the kyphoplasty, 86 VCFs in the vertebroplasty, 83 in kyphoplasty. There are 25% males in both groups. Median age of the patients is almost similar. Follow-up period is 12 weeks. The most frequent reason for the fractures is simple fall on the ground in both groups. Most of the fractures are between 10 to 30 days, like age of fractures. The level of fractures in the groups in the vertebroplasty, we have mainly with 2 levels, in kyphoplasty 1 level. The levels distribution of the vertebra. The patient's clinical outcome was evaluated by the visual analog scale or Swiss disability index. The clinical outcome comparing both groups, in both groups we have similar results. 2 weeks post-op 2.7 compared to 2.4. Swiss disability index 36 to 35. Regarding the restoration of the kyphotic angle, we have median change of COP angle of 7.2. The cement leakage, we have almost 90% cement leakage in the vertebroplasty group. And in the kyphoplasty, almost 11%. This is, I will go further because I don't have time. Several cases with vertebroplasty. So I don't know, it's not changing very fast. Production. 4 levels. We're doing it at the same time, introducing the needles. Kyphoplasty. Another case. Just a moment. So regarding, there are many cases for vertebroplasty in the literature. Regarding them, our results confirming exactly the results of this series. In experienced hands with appropriate patient selection, vertebroplasty is safe and very effective procedure with a low complication rate and very high success rate. However, it's a palliative procedure. It doesn't correct the osteoporosis. We need a medical management of osteoporosis. Regarding the kyphoplasty, we need a long-term follow-up to evaluate, to determine whether the improvement in spinal kyphosis will reduce the disability, morbidity, or the risk of subsequent VCFs. However, in the kyphoplasty cases, we have almost immediate pain relief. The pain relief was sustained for up to 6 months after the procedure. The majority of the patients also reported a return to the pre-fracture functional levels. Comparing the both techniques, the answer of our question from the beginning, vertebroplasty or kyphoplasty, both techniques have the similar, almost the same clinical outcome. However, kyphoplasty is better in increasing the height of the vertebral bodies. Kyphoplasty, however, is more expensive, time-consuming. Of course, kyphoplasty is associated with lower rate of cement leakage compared to vertebroplasty. But in most of the cases in our practice, if I have to recommend to some of my colleagues, I will recommend vertebroplasty. So thank you. Thank you for your attention.